All right. Welcome to the December Board of Health meeting. We're glad that you're here. I would like to particularly welcome Brian Doucette, who's on as well, our Berrien County Administrator. Brian, would you like to say hi? We're just really glad for your leadership.
Thank you very much. I'm glad to be here, and I appreciate the invitation. Thank you.
All right. Thank you very much. So our first order of business is some approvals. Thanks to Kim, we have minutes. May I have a motion for their approval?
Ray will approve. We'll make a motion to approve as written.
Ken Edwards, second.
Okay, Ray approved. Ken, second. Is there any discussion? All those in favor?
Aye.
Opposed? Motion carried. Lisa, we're moving on to vouchers. I see that you have a couple of the vouchers boxed. Would you walk us through those that are out of the ordinary there?
So the boxed items that are basically a little bit different than we normally see. The first two I have boxed. The first one is $15,590 as capital that was purchased related to COVID. That was the tent purchase. The second item, we purchased a couple of tents for our drive-through clinics. Second purchase listed there was $32,689. That was for a new truck, basically that will be able to, that has the capacity to pull our trailers and the tents. So that was a new 2020, very, very pretty red truck. And
Red.
We never get new vehicles. We always get the cast-offs.
This one's really spiffy. And the final item on the last page of my list there is $5,135. It's coming out of our Kresge grant for some staff leadership training. So that's coming through also in November.
Yeah.
Questions? Any other items?
Right.
I have a question.
Yes, Lisa. Linda. Yep.
On my voucher attachment, I see $137,000 and $1,037. Or $1,076. Am I missing something?
So that's the summary page, Lisa.
Yes.
The roll up.
The 137, Linda, is basically the total of all those charges above.
Okay, that's fine. That's fine. Thank you.
And the 107.6, why is that pulled out separately?
I totaled the 107.6 is coming out of our communicable disease fund, which is on the general fund side. And then the 137,794 is coming out of our fund balances, our health department fund balances.
Okay. Any more questions? May I have a motion for approval and a second support? Joe?
Yeah, I'll make the motion.
Okay. May I have a support, please?
Support.
Okay. I saw Linda's hand first as a support. Any discussion? All those in favor?
Aye.
Aye.
Opposed? Motion carried. All right, we're moving on to 4 resolutions. I would like to do the first 3 together and then take the 4th separately, if that would be all right. All right, Courtney?
Yeah, so the going over the first three then, the first one before you is our annual contract with the Department of Environment, Great Lakes and Energy, so EAGLE. We've been EAGLE for a couple years now, but the Michigan Department of Environmental Quality, if that reminder is helpful. But this is just our annual agreement that we get. It usually does come a little after October, but it's an October 1 of 2020 through September 30th of 2021. And this supports a number of our environmental health functions, non-community water, drinking water monitoring, public swimming pools, septic, and campground inspections, among a few other things. So that is for your approval and acceptance. Otherwise, nothing too new in that agreement.
Courtney, is that pretty much what we've gotten in other years?
I think that is fairly comparable. Lisa, do you know if that is a little
yeah,
higher or lower?
It's really close to last year. Last year we received $46,426. So, and they're packaging up our contract this year just a little bit different. So, a slight decline in the overall contract at this point.
Okay, thank you.
Great, thanks, Lisa. The second resolution before you is acceptance of funding from the Local Community Stabilization Authority. If you'll remember, about a year ago, I think this is the second year of funding. Lisa, correct me if I'm wrong, but a year ago, this was new funding to local public health out of the Michigan Department of Health and Human Services. It is a similar amount to last year. I believe we are anticipating getting this each year, but we don't know until it comes. But we're asking to accept $158,522. And this all does go into support essential local public health services. So it is specifically designated for those services and to support functions here at the health department. And that is a renewal and acceptance of those fundings for year 2.
Courtney,
Yes.
real quick question. What could you give a couple examples of what that funding is supporting?
Sure. So essential local public health services is some of our like restaurants, so food inspections, immunizations, STD, any of those essential public health mandated services. Is that helpful, Ray?
Yep. Thank you very much.
Great. All right. And then the last of those first three is a request to apply for funding. This is funding that is actually designated to each county. It's more of we get to opt in if we want to accept that funding, but we do have to submit kind of a short proposal that says how we will use that funding and how we intend to utilize those funds. This is a grant that would be to the Department of Licensing and Regulatory Affairs, so LARA. It is for the medical marijuana operation and oversight grants. This would be the third year that we have this funding. It would be a continuation on our Dirt on Weed campaign that has been really successful, had a lot of traction. We are in year 2 of that. Jillian, do you want to say anything else about that funding or the Dirt on Weed campaign? I know you've been our instrumental one in moving that forward.
I mean, the plans, just like you said, to continue for another year. We haven't done kind of a summary report of how that went this year, but we were able to do some new and cool things that were really successful overall. But I think we would continue to find some innovative ways to get that message to our community and really build awareness among some of those priority populations about marijuana. The grant, as Courtney mentioned, is designated under a medical marijuana kind of bill from the legislature, but there is the ability to also do education about recreational or adult use marijuana also.
So kind of wrapping up this last year of work, but there was a really great partnership this year with Van Buren Cass Health Department as well. So we're able to really take that regional approach to messaging. So that's something else we'll hope we can continue.
Oh, that's great. So we have 3 resolutions before us. May I have a motion for approval?
I move it.
Okay, so Dr. McBride moves. May I have
I
a
will
second?
second. Ray will
Ray
second.
seconds. Discussion of those three resolutions.
I mean, it sounds great. You know, this is wonderful. Keep us going, gives us stabilization, allows us to do positive things in the community. Wonderful.
Well, I have a question, not so much an approval, but has there been any data or feedback on the impact of legalizing recreational marijuana? I know we had a lot of concern about that. I've heard very little feedback since that's been legalized.
Yeah, that's a good question. I don't have that here in front of me. That's something we can certainly bring back to the group. I think that would be a good round out and maybe part of some of our annual report that we give of the work that was done over the last year. So Joe, I'll make note of that and we can bring that back in. Dr. J, I don't know if you want to say anything to that. I know you do some of that, the following there. What are your thoughts?
Well, just that the sales are exploding, and you know, there's more and more evidence that a certain percentage of people will become psychotic, and you know, there's lots of negative evidence out there and stuff like that. But Courtney's right. I'd have to have a little time to come back with some actual data. But I know I've seen, for instance, the sales in Kalamazoo. There's a couple of robust places there. The amount of money that they're generating is absolutely incredible. The sales are through the roof, probably helped by COVID.
We'll certainly put that on a future agenda to bring back more information.
It's a good question.
Right. Yeah, okay, that's good. I was thinking maybe looking at that Dirt on Weed campaign as well as a report. So all in favor of approval of the first three resolutions?
Aye.
Aye.
Right, motion carried. I don't see any problem with the fee schedule, but it is a very serious decision to recommend to the county board. So I wanted to just keep that separate for discussion. So that's the next thing, Courtney. Thank you.
Yeah, of course. So the resolution before you is to approve our 2021 fee schedule. And I'm going to actually invite Lisa in. She has done the heavy lifting on that fee schedule. So Lisa, if you can walk us through that.
Sure. So this year's the 2021 fee schedule to go into effect on January the 1st. Basically, there were not, I didn't make changes to the environmental health rates. First of all, after discussion with Nick, and where we put rates as of the January 1st of 2020, I think we're in good shape. I'm seeing some revenue increases, and our rates never totally cover our costs, but I think we're in good shape there. And kind of what we discussed with the stress on businesses right now with COVID, it just seemed to be a good year to kind of hold steady. On the admin side, which is the very first page of the schedule that you received, again, there's no increases in there. There's some general administrative rates. And then the second sort of section there is substance abuse. Also, after discussion with Lisa Peoples-Hurst, we're not making any changes to that schedule. And we've added another drug kit that's available for purchase by the public. Also, we have urine and saliva tests now. So clinic fee schedule. So basically we go through a review line by line, CPT code by CPT code to make sure that we are covering both the potential maximum amount we can receive of reimbursement. A test and sort of an overall restriction is that we cover our costs. Unfortunately, again, our fee schedule does not cover all of our costs. So we're never in danger of exceeding that metric, but I go through and basically compare our rates to other health departments' fee schedules. I go through a line-by-line review against the Medicare, Medicaid, MDHHS listed fees, and then do an overall kind of rate and cost review. So the items that are highlighted on your list are those that, again, we're anticipating higher reimbursement rates from third-party payers and Medicare, Medicaid. So were there any specific fees that you would like me to address, or any questions?
I have a question, not so much on the fees, but in the past, we've had questions about the billing system capability and whether we're doing adequate billing and follow-up. And so I'm just wonder what the status of that is.
I actually think, Joe, we've improved somewhat, although this is a really hard year to kind of get a handle on that. So generally, what I sort of like to see is an increase in revenues. And this year, because we've had clinic closures and different challenges, I don't have a real good handle on that. I think that where we have improved is a more timely recording of our receipts. I'm comfortable with the accuracy between there's two systems we're booking in, both on the county financial side and on our billing side. So I am definitely seeing some improvements there. I think our collections are better. I think they could, again, be better than where we're at right now, but I think we're doing pretty well.
Other questions for Lisa on the overall fee schedule or specific items that are listed here?
Lisa, Ken Edwards here. Just an observation. As of January 1st, Medicare is getting rid of E&M coding distinctions.
I believe that's true, Dr. Edwards. I haven't seen the, I think my understanding is they're going to consolidate some of the E&M.
Yeah, they're basically going to get rid of the 1 through 5, and they're going to go to one code, which can have an impact. The second is, do we generally accept whatever insurance a patient has when it comes to these different items?
Yes, I mean, we will, when the patient comes into the clinic, we definitely review their insurance, make sure they're in network. Again, if a client comes in without insurance, then we have a sliding fee schedule that we apply that's based on income. And pretty much we will serve anyone who comes through.
All right. Any additional questions on the fee schedule?
Oh, Peg, can I
Yes,
say one
Lisa.
more thing? So Dr. Edwards, I think there's a couple things that may change as we get into 2021. We may be expanding on our telehealth capacities. That I believe is going to become more and more part of our activities, and potentially as the year goes on, if there are large changes in our cost for a particular service, we would make revisions to the fee schedule and run that back through the board.
Thanks.
Thank you.
All right, you have the fee schedule in front of you to make a recommendation for approval to the Berrien County Board. May I please have a motion for approval?
So move, Linda.
Okay, Linda moved. Is there a second? Was that you, Joe, saying
Yeah.
support? Okay, so Linda moved, Joe supported. Any discussion? All those in favor?
Aye.
Opposed? Motion carried. I am not pleased, Bill, to do the next item. You have been a straight shooter, a good communicator with from the Board of Commissioners, and I just can't tell you how much I appreciate your leadership. We have a resolution here thanking you for your time. Just can't say enough about what a pleasure it is to work with you.
Well, thank you, Peg, and thank you all for the resolution. It's not a necessary thing, but I very much appreciate it. I'll have some comments during my commissioner report, of course, but the pleasure and the honor has been a two-way street, as you say, Peg, because this has really been a great experience for me, and I'll comment on that. But thank you all for the resolution. I very much appreciate it.
Would others like to join in and share some of the pleasure of Bill?
I'll make a comment. Ray, Bill, it's been a real pleasure working with you, and I appreciate all the insight you brought, some specialties where we've had some issues. That's where your background, which was fantastic, and I wish you good luck for going on.
Thank you, Ray. I may come over and borrow your RV to.
Anytime. You know where I live.
Well, as soon as you get the vaccine, Bill, I have to wait for the vaccine.
That's why we have it, the distance right up front.
Yeah.
No, I really appreciate, Bill. You know, you really are able to kind of give us a perspective how the commission might see some things we want to do. And I think that really helped administration prepare for their meetings with committees and the board. So that kind of training of how we should approach the issues with the board has been, I think, invaluable to us.
Well,
I'll second all those comments, and also thank you for your time on the county commission. I think you've been a real asset, and I know we'll miss you and they will miss you.
well, Joe, thank you very much. It's you guys are a great group to work with, I'll tell you.
Well, and on behalf of the staff, I'll just echo what Dr. McBride said. We've really appreciated the continuity and being able to have that dependable liaison with the Board of Commissioners and just the insight that you've brought to us as an admin team and the Board of Health. So thank you very much.
Thanks, Courtney. Like
And I
said,
second
I
that
will
also.
have
Thank
rebuttal
you so
later
much,
on.
Bill. Thank you.
Okay. Yeah.
Dr. J, thank you.
All right, Linda, did you have a comment as well?
Yeah, I think it's been really, I think it's been really helpful as a board member to hear perspective, and very reasoned and very balanced perspective on that I think helped staff and certainly helped me understand the commissioner's side and how we might be able to do what we want while honoring what the commission has to do and what they need to do for the county. So I think that was very helpful to me, and I suspect also possibly to staff. So thank you, Bill. Everybody will miss you, I'm sure, but you'll be off playing golf and seeing your dermatologist.
Yeah, she's hacking away at me. So thank you.
Sure. Well, you know, you've really given form to what it is to be a public servant. So thank you. I really appreciate it. So we have a resolution here honoring what Bill has contributed to us as a board. May I have a motion for approval? Okay, Vanessa, thank you, is moving for approval. Is there a support?
Ray will second.
Ray will second. Any discussion? I guess we've discussed. So all in favor with a rousing thank you,
Yay!
Bill.
Hey.
All right, we appreciate you. Thank you.
Thank you.
Brian, I would ask that you would make note for the commission, if you would please, that we just have appreciated what Bill has done, and we look forward to whoever is appointed. But if you do that, I'd really appreciate it.
Not a problem.
All right, Lisa, we have our financial report in front of us.
So to run through a couple numbers, Revenues, state and federal grant revenues through October are 570, almost 574,000, which is 18% over budget. And we're 11%, 387,000 favorable to last year. Of those increases, 456,000 is COVID-related revenues. Permits and inspections are actually doing way better than I thought we were going to end up. So we're favorable to budget. Again, there's some timing issues here, and this is through October, but we're favorable to budget 63,000 and over last year, which is probably a good reflection on where we're going to end the year. We're over last year, almost 17,000. Food service licenses have been down. I think we're going to be 5,000 or 7,000 under. There was 195,000 budgeted for those licensing, but I'm seeing some good increases in septic, septage, and well permitting. So I think that's going to offset any decreases we have in food service. Medicaid, Medicare, private insurance, and clinic revenues are under budget 85,000 and are down from last year 23,000, which is about 14%. Again, the clinic has we closed the clinic in March due to COVID for in-person visits, and that's definitely having an impact on our revenues this year. I'm projecting that we're going to end the year about 85,000 under budget. Federal in-kind vaccinations. So that's through September 30th. That entry is now in the October year-to-date books. We're under budget 25,000, and we're under last year 49,000. Doses, vaccine doses that were distributed fell 1,077 doses from 3,813 doses for year ended this September 30th of 2019. We fell down to 2,736 through this December. It's a decline about 28%. Our local decline was actually less severe than the state average decline was about 33%. So we did a little bit better, but again, there's a COVID impact on vaccines. On the expenditure side, overall, we are favorable. We're under budget 175,000, which is about 3% year to date. We're actually over last year after I adjust out medical examiner and water filter purchases last year. So we're about 440,000 over last year. It's about a 99% increase. Most of the increase you can see is in the personnel related line. So both salaries and benefits were just under budget by about 3% through October, 128,000, but we're over last year by 544,000. That's about a 14% increase. So it's kind of a mixed bag here. So the variance to last year is partly because there's an extra payroll in last year's numbers that aren't in this year's numbers yet. There's also the increase. We have step and salary increases, which basically account for about 4 to 5% of our salary year over year increase. And there was an increase in our benefit rates in 2020 in comparison to 2019. COVID is also making an impact on our staffing lines. We've had overtime totals through October of about 32,000 related to COVID, and temporary help of about 49,000. And we're beginning to see the impact of the full-time staffing ads. So I'm projecting that we will, the overall added staffing costs for 2020 are going to be in the neighborhood of $227,000. To kind of go on with COVID expenses, through October, we have spent $778,000. I checked overall spending through this moment. We've spent just a little over $1 million on COVID-related expenditures so far this year. Of the 778 through October, 709,000 of that was for staff and overhead. We've got about 29,000 in computer and equipment purchases. 15,000 on supplies and postage, PPE, and about 23,000 for testing, some web page development, and contracted services. Just some general items. The contracted services line within the expenditures is 66,000 over budget. Again, that was part of our King Media contract that wasn't in last year's budget. We received that grant as the year, I think it was about January of this year. And also Area Agency on Aging, we have a med management grant that also wasn't in the budget. So that's running through our October expenditures. Travel is under budget 42,000, basically due to COVID again. And equipment purchases, you can see the 41,893 that were over budget. About 29,000 of that is related to COVID response activities. Through October, revenues exceed expenses by 287,000 on a cash basis. The fund statements, which are also part of your package, indicate that we're projecting to be our overall deficit by the end of this year. We've gone from 528,000 use of fund balance to I'm projecting about 167,000 use of fund balance. So we will carry over at this point about 1.4 million health department fund balance into 2021. Any questions?
That's really good. I'm amazed at the carryover. So
we're in good shape.
Yeah, that's terrific. Any questions? Thank you, Lisa. Your ability to explain what's going on is just absolutely phenomenal. It's a breath of fresh air. Thank you so much. I appreciate it. All right. We've all had questions about COVID. Courtney, I know you've listened to some of our questions and we look forward to hearing from you.
Yeah, so we're going to take a bit of a team approach this morning and cover a myriad of topics for you. So certainly if more questions come up or we don't hit one this morning, please ask it, but we are going to work to cover. We're going to go over some data and I'm going to have Jillian do that here shortly. We'll talk a lot about case investigation this morning and give you an update on where we are with that. And then really spend some time giving updates on where we are with COVID-19 vaccination planning. I know there's lots of questions around that, and that's a impending effort for the department, as well as just some communications that kind of swirl around all of those topics. So hopefully we'll get to all those questions. Please bring them in, but no, we're going to get through all those big topics. To start us off, Jillian's going to walk us through some of the current data, just so we have that to kind of position us this morning.
Okay, so hopefully you guys can all see this this screen here. Okay, so just looking at our dashboard here kind of as an overall summary and look at some of the major things that we're tracking and information that's available publicly. I mean, as you can see down in this corner here, we've got our confirmed cases by referral date. This has significantly increased, as we know, from that beginning of October when we started to see our cases start to climb. Back in May and in July, when we had our smaller waves in the beginning of the pandemic and in the middle of the summer, those are almost flat lines now, and it's hard to even decipher when we had those first waves, given the sharp increase of cases that we had here in the last 6 to 8 weeks. So our confirmed cases climbed very rapidly. Probable cases are still growing a little bit slowly. People move in and out of this category as they are, as testing might happen. They might be moved into a probable case category if they are connected to a confirmed case and feeling symptoms. If they are tested and subsequently are positive, they get moved out of the probable case category into the confirmed case category. And similarly, if they test negative, they're just moved out of that line completely. So one note I wanted to just make mention of here on our dashboard is regarding the recovered individuals case count here. We were counting our numbers of recovered. Anybody who was moved out of that isolation period, once their case was considered closed, we would count them as recovered. But as Courtney will speak a little bit more to shortly, we have had to make some prioritization changes in the case investigation process that we are doing and really make sure we're making the best use of our resources, of our staff, and having the biggest impact. That doesn't necessarily allow us to follow very closely every single individual person and case. So we now have standardized our recovery definition to more closely align with, align with what the state uses, and that is a 30-day recovered time frame. So basically, if you have had confirmed COVID and you make it 30 days, you will be moved into that recovered status. We know that there are individuals who still have lingering or longer term effects from COVID, but if they do not pass away in that 30-day time frame after their case diagnosis, they are moved into that recovered case count. So that was a change that happened just within the last month. We have seen our death numbers increase over the last 6 to 8 weeks as well. Most of those are due to COVID cases in long-term care facilities and skilled nursing facilities. We know that deaths are still very common amongst those older individuals, those with chronic underlying conditions who are most vulnerable to the severe impacts of COVID. And that seems to be what is driving most of the deaths that we see in Berrien County as well. We still have our map here. We aren't necessarily seeing any really significant geographical trends. The places where we have higher populations, our Niles area, Benton Harbor, St. Joe area is where we have the most amount of cases. And that is to be expected. Where more people live, you're probably going to have more cases.
Jillian, question?
Yes.
What we're recording here is really kind of a pass-fail measurement. When is the medical community or the media going to start talking about that group that have longer term issues? That seems to have been kind of lost in the discussion so far, but I read that is an increasingly large medical issue.
Well, Bill, you look at, sorry, let me jump in here. Bill, when you look at long haulers, which is, it was highlighted on 60 Minutes, I think, at least these patients. And so it's difficult to even know what symptoms you're tracking because people are presenting with a myriad of different post. Ones are COVID related, which aren't COVID related. I think that's going to be in a later analysis, but it's an excellent question that everybody's thinking about and we're seeing in our practices.
Thanks, Ken.
This is Johansson. Ken was breaking up, at least on my phone. I couldn't understand it all, but the majority of the people that are when you dig into who are the long-term cases, a lot of them appear to have like post-traumatic stress disorder. A lot of it is mental health issues. And it's like Ken said, it's hard to parse out for some of the people. Is it their heart disease they already had, their hypertension they already had, chronic obstructive disease they already had that, you know, is still a part of their thing. And now COVID is blamed for it. So it's hard to say. And one of the bigger groups that it's when you hear people with long-term effects who are answering surveys is they haven't regained their taste or smell yet. So in terms of the number of people with like persistent lung disease and heart effects, that appears to be a relatively small number, but Ken said it's going to take study and time to actually, you know, parse that out.
Thanks, Dr. J.
I had a question on the numbers, you know, as we're following them. I noticed in Michigan, Detroit had one of the lowest of the city had the lowest incidence of COVID infection almost anywhere in the state. And I'm wondering, I'm sure it isn't a better compliance issue. So I'm wondering is that herd immunity maybe setting in? They were very high, among the highest of high in the beginning, and now they're the lowest. So I thought it was an unusual change. Any thought on that?
I think that reflects where COVID has really zoomed through to a large number. And I think, so herd immunity is part of it. And part of it's also a fear factor of people just being more careful. And, you know, in terms of the death numbers, when it runs through nursing homes and communities, that's when, you know, deaths happen. 70+ % of our deaths in the last month or two are all either LTCU or hospice. And our median age remains above 80. Our average age remains above 80. So that's the group. And when you look at other states, you know, New York and other cities that got hit hard, their numbers are down now. But if you look, when you hear the media reports saying second surge in Texas or here, whatever, a lot of times it's in other cities. You know, it is definitely going back to some of the same cities, but it's driven in large part by, in Texas, for instance, the whole El Paso area, which had nothing in the spring, is really getting really hard hit now and driving their numbers up. Similarly for us, just in terms of long-term care units, we had one long-term care unit that had no cases last spring, none. The same place that was run by another place, by the same basic home company that had lots of cases. Well, that case now is our #1 site, and they're ones that had none the past spring.
Okay, I will move on here. So this next graph that you see is the 7-day rolling average of confirmed cases. Again, you can see kind of our little waves that we had in the spring and in the summer, and then our very sharp increase here that we started to have in the fall. You will note here in the latter part of this graph here, there seems to be a little bit of a dip. Right now, we need to have a few more days of data to know whether, you know, what the numbers are doing here, if this really is just a reflection of the fact that testing locations were closed, most of them for the long holiday weekend we just had, or if there really is a slowing down, a leveling off, or even a reversal of this trend. So we do need to just have a little bit more time to note what might be happening here. It is important to note that, you know, we were experiencing exponential growth with our numbers of new cases doubling about every 10 to 14 days through this time frame. But we also know that our testing capacity is going to reach a limit at some point that we just won't be able to test, and we would not see that exponential growth continue up, because our testing capacity just would not be able to measure that growth. And then here you'll see the 7-day rolling average of the % of positive tests. So again, we saw this sharp increase here in the fall. At our highest, we were having about a 21% of positive tests that were coming back. That was exactly what we were experiencing back in the spring when we were only testing very, very sick people. So again, you know, we are seeing a little bit of a dip here at the end of our graph that we'll need to be monitoring a little bit more closely. That could be, again, an artifact of those reduced testing numbers that happened, you know, at the latter part of last week. So we need more time to really fully assess that. But it is important to note that with the levels of community transmission that we are experiencing right now, the % positivity for testing just adds a little bit less color than to the total picture than maybe it used to, especially as some testing sites, for instance, Spectrum Health Lakeland, are really testing only symptomatic people and preserving their limited resource of tests that they have available. So seeking out and only testing symptomatic people will artificially increase the percent positivity. So hopefully testing will be able to continue. There are many sites that still test asymptomatic individuals as well, but that is just important to know about this figure. It is also important to remember that we have had an increase in the amount of testing that's happened. You'll see here, this is a snapshot from the My Safe Start map that is put together by MDHHS. And so here from September through now, you can see that we have had an increase in the amount of testing that has happened in Berrien County daily. However, it is not nearly enough testing to explain the sharp increase in cases that we've had. This slow and steady rise is nowhere near the sharp increase that we had in those cases during the same time frame. So again, you can start to see this little dip here. This might be due to the holiday weekend and a decrease in the tests that were conducted then. So moving right along this graph here is the number of hospitalizations. It's the inpatient census for Spectrum Health Lakeland. And again, this goes all the way back through April. So you can see, some of our little waves that we had in the spring, a little bit here in the summer, and then obviously a much more significant burden of hospitalizations here in the fall. So we are seeing just at the end of this graph here, a few days of stability. This could be a very encouraging sign. However, we do know that with hospitalizations, there's often an intentional action to discharge people before a weekend, a holiday weekend specifically. So this could be artificial, but we are, somewhat encouraged by the fact that it's leveled off there. So we do also know that with some of the new monoclonal antibody treatments, these are outpatient treatments that are available through Spectrum Health Lakeland now, that they might be discharging people and able to get them into some of those outpatient therapeutics. So that could also help reduce some hospitalizations, but we definitely will need to be monitoring this trend closely, especially in the next couple of weeks, as we do anticipate there could be a rise in numbers of cases and potentially hospitalizations following the holiday weekend where there was most likely transmission occurring. At Spectrum Health Lakeland, staff seems to be the biggest limiting factor and stressor for the system. It's not necessarily that there aren't enough beds available, but the numbers of staff that are needed to care for every individual patient seems to be strained. So that is something that we're definitely in a lot of constant communication with our partners at Spectrum Health Lakeland to understand the trends that are happening at the hospital. We really did start to sound the alarm about the fact that hospitalizations were rising about a month ago, maybe 5 weeks ago, and really started to put out there, we need to be concerned about the capacity. We need to make sure that we're taking care of our staff at the hospital, that they can stay healthy themselves and not be burned out and be able to have enough numbers to care for all of the people who need care. So hopefully people are listening to that. Hopefully that has appealed to people that we need to make sure that we are doing our part to prevent our hospitals from becoming significantly overwhelmed. And then the last graph we have here to share is the number of deaths by day. So we know that, Dr. Johansson was just speaking about how we have some more significant numbers and COVID transmission happening in some of our long-term care facilities and skilled nursing facilities. So it seems to be that we're having another sort of wave that is circulating through a lot of those facilities at this time. That is being reflected in some of the cluster of deaths that you see here over between October and November. And to Dr. Johansson's point, there has not been any change in the demographic trends that we're noting with the deaths. The average age still is of a death is over 80, and the vast majority of the deaths do occur amongst long-term care residents or individuals who are under hospice care. It doesn't make these deaths any less tragic and for our community and for the families that are left behind. but we are encouraged by the stability in these trends. That's important to note. But we are still very much saddened to see the loss of life that we are experiencing here in Berrien County. That is all that we had to share. So I'm going to go ahead and stop sharing. And as a team, we can answer any further questions you guys might have.
Yeah, and I don't want to cut off questions about data, so we can bring those forward. We are going to move into case investigation and COVID vaccine. So if you have questions there, we can cover those topics first. Okay, we'll keep moving ahead. And if those questions are there, please bring them forward. So, I mean, with all of this, of course, I know we've talked a lot about case investigation and contact tracing. That is certainly the heft of work that has continued to move forward over the last weeks. As we predicted a bit at our last meeting with those growing cases, it really has strained our capacity to reach out to every individual person. So we've had to make some of those modifications to ensure that we're doing the most meaningful case investigation and getting to those highest risk individuals. And so Candy, I know that you were going to talk a little bit about what we're doing and what we're seeing in case investigation. So if you can jump in and share there.
Sure. So currently, recently we had our highest day of cases, or positive cases, and that was on 11/27 with 214 cases. Now, yesterday, in talking with Donna, we had about 50 cases, new cases that were positive. So that's quite a drop. We'll see what happens the remainder of the week to see whether or not those increase from the weekend. So currently, our staff are working 7 days a week. They are covering weekends in order to maintain. They're working 2 priority groups right now. The first priority group is anyone who is 65 and older, that they're targeting those folks first. And the other group is anyone 18 and younger. So the group in between, they're getting, letters are going out to inform them that they are positive for COVID and instructions on isolation and quarantine. So the 2 major groups we're currently working on does not include the 18 or 19 through 64 group. Those are just getting letters sent out. We have a system called Sarah Alert. And so if we are able to speak with them, we put those folks that are contacts on Sarah Alert, and they are updated every, I believe, 2 days or so, depending on how often they want to be contacted, just to keep tabs on them and see how things are going. We were working overtime on a daily basis in order to try and just somehow keep up. I know that in the past couple of days, nurses and case investigators have actually been able to leave on time, which is 5 o'clock. So that's kind of nice. That's a nice breath of fresh air for those folks who have been working relentlessly 7 days a week. So I don't have any other information unless anybody has any questions.
I think just to add, oh, go ahead, Joe.
Oh, no, I've been reading where they want to reduce the quarantine times from 14 to 7 days. I don't understand the scientific data behind that, but is that in effect yet? And what would that not alleviate somewhat the staffing at Lakeland and maybe other facilities and services?
So that's a good question. That is something that is not yet there is no official move to do that yet. That has been something that we've heard talked about, that there has been discussion about at the CDC and other levels. So we are certainly watching that really close. Just to clarify those timelines, what's been talked about that we've heard and that we're watching is the move of the quarantine to 10 days. With a potential option that if there is a negative PCR test or negative test, I guess, in day 5 and above, and it's negative, you could be released early from quarantine. So that's clearly a shift from what we've had, where you've had that 14-day quarantine and a test has not altered that timeline. This is not an official move yet. At this point, it is a 14-day quarantine. It is not, I know that these words get interchanged and mixed often, but the isolation. So if someone actually tests positive or is symptomatic, that is not being altered. That will stay the same. So from a standpoint of like burden to health system or to public health, I don't know that this means a lot from like the daily work that we have to do if this testing component is thrown in there for a shortened quarantine. Honestly, this goes back to Jillian's conversation of our testing capacity has its limitations. There will not actually be enough tests to have every asymptomatic quarantined person test and get that result in a meaningful amount of time to then alter that quarantine period. So it's a really good question. It's something that we're watching really closely because it would certainly alter some of our guidance and some of the ways in which we have been supporting families in that quarantine period, but there's no official change there right now. I know, Vanessa, you had asked this at our last meeting, and this goes with our case investigation. While our cases have grown exponentially and we have not been able to have some of those personal touch points with everyone, we've really been able to utilize this time. It's a kind of an ongoing quality improvement period of how do we make sure that we're having meaningful touches with everyone, but giving the due diligence that's needed. And so we know a lot of our families, when they're impacted by either isolation or they're identified as a close contact and they're in quarantine, there's impacts to employment and where food is coming from and how they're paying their mortgage or their rent or whatever those myriad of things are. And so what our goal is we have about 3 different phases of case investigation that, depending on where our caseload is, we can kind of move forward and dig in deeper and get to everyone, or roll back and get to those high priorities with giving others that touch point. And so that touch point is the letter that Candy referenced. And so everyone who is a positive either gets a call directly from us, and those are those 2 extreme groups, because we're trying to either identify those school age cases and support our schools and our symptomatic students, or that over 65 who are at higher risk for those adverse outcomes. So really touching on the middle group, though, we know we have a lot of families and people in between, right? So that letter has a couple different resources there. One, it's connecting people to 211 and other community resources to make sure that they're still getting all the wraparound touch points. I think the letter has increased our hotline flow. We're regularly taking in the 3 to upwards of 400 calls on a weekly basis to our hotline. And through that, we're helping support people with food needs. We have a process to draft letters for employment. That has been a really large request of my employer needs to know I'm in isolation or quarantine. So we have that process where someone can quickly request that and get that letter back, or be connected to other services. So we've been doing a lot of that wraparound piece that supports the case investigation piece. Any questions about case investigation before we move into COVID vaccine?
Can I just add one thing to Joe's point? The science does support the shortening of the quarantine period, and other countries, including France and Germany, have done that. And there also is discussion on shortening the isolation period, because the majority, more than 90% of the people, are done shedding by the time 5 days from the beginning of their symptoms. So they're actually looking at that one also. But they anticipate that by the end of this week that the quarantine period will change. And to me, one of the greatest things about the change in quarantine is the decreased disruption to families, and maybe there'll be increased compliance if people are told it's 10 days and not 14 days, or or whatever they drop it to. Although it appears that it's going to be down to 10 days. I think it's going to happen, and I think the science supports it.
And increased compliance is a good thing, right? If someone's going to at least do that helps us overall.
Yep.
Yeah. Okay, so one of the big focus areas right now is really starting to focus on the distribution of COVID-19 vaccination. I know that there's been lots of different news articles and things about that of late. We are really gearing up to potentially have some of that initial vaccination here in December yet. I will kind of preface all of these dates I will share as they are moving targets, and they are current dates we're planning on, but nothing is set in stone right now. We've here at the health department been In internal planning meetings to think of distribution, again, this really follows a lot of our principles of mass vaccination. So how we would do a flu clinic or any of those other clinics. We got a lot of practice this fall doing our drive-through flu vaccination clinics. And so a lot of that was in preparation for COVID-19 vaccine, to be able to kind of exercise some of those muscles, to use some of our new equipment, and to just remind our staff what do those muscles need to do in a drive-through vaccine setting, because that is different for us. We've often planned to have more of a clinic setting and having people into a giant auditorium or gymnasium, which is not really the case right now. So with that, we have been really watching the release of vaccines. So you may have even heard last night, the Advisory Committee on Immunization Practices, so the ACIP, has made a recommendation for who will be the initial individuals to get that vaccine. A lot of this, again, is moving pieces, but right now there's being talked of 3 tier A categories. So there's a tier 1A, tier 1B, and tier 1C. 1A is what the recommendation has been made for so far, and that is who is first up. That is healthcare professionals and providers, and then long-term care residents in like community congregate care settings. And so that recommendation still has to be formally issued from the CDC, but that is what was voted on last night at the ACIP meeting. So what that means for us is a lot of closely aligned work with Spectrum Health Lakeland. So in local communities and local jurisdictions, health systems, federally qualified health centers, and local health departments are kind of the 3 large bucket organizations that will receive vaccination and have responsibility to help distribute that in the community. Health systems are primarily charged with taking care of their own staff and any associates who are tied with the health system. The federally qualified health centers do their own staff and any associates. And then the local health department is really responsible for all of those non-catchment areas. So think healthcare providers who are not tied to Spectrum Health Lakeland, urgent care, MedExpress type places, EMS, and then also our long-term care staff. So all of our long-term care, our SNFs, and our assisted living. So there's a pretty large group that falls into that healthcare provider. And then in the last night, they've added in residents. And again, that's really reaching out to those who have that direct exposure and have that in their daily work life or are at that highest risk. And so that's where some of those decisions have been made. When you move into the 1B, the groups that are being talked about in that second tier would be your essential workers and your critical infrastructure workers. There's still a lot of discussion happening around that, so I anticipate that there will be changes. But talking about, some of your pharmacists and other healthcare providers who you might not get to in 1A, but then adding in some of those critical infrastructure. So think grocery stores, water, roads. Our public health staff kind of fall in both of those tiers. So our nurses who will actually do COVID vaccine would be in that tier 1A. The rest of our team would be more in that tier 1B. And then 1C is the final of that first tier. And that's really where they're talking about anyone 65 and over or community members with other chronic health conditions. And so right now, we're really focusing on the 1A. There will be limited supply when it first comes out. We're looking at either the Pfizer vaccine, which is the one that needs that ultra cold storage, so -70 Celsius, or Moderna, which could come out fairly quickly after the initial release of Pfizer. That needs a little bit more of a normal storage capacity for us. We could actually store that here in the health department. We have begun to have weekly meetings with Spectrum Health Lakeland to just continue to have those vaccine planning conversations. Spectrum Health Lakeland here in St. Joe does have capacity to store the Pfizer vaccine. So one thing that we don't have before you today, but we're working on to take to the Board of Commissioners is an MOU with Spectrum Health Lakeland that they would be able to help us store that Pfizer vaccine so that we would still be able to accept that. So we have answered favorably to the state that we could accept the Pfizer vaccine if we are able to get any of that. It would be stored for us at St. Joe Spectrum Health Lakeland, just to help with that ultra cold storage. So we're working through all of those pieces. Right now, the tentative dates are, the FDA is scheduled to meet December 8th, 9th, and 10th. That is to review the EUA, so the Emergency Use Authorization request for the Pfizer vaccine. And right now they're anticipating that by the 10th, that EUA will have been issued. Then the Advisory Committee on Immunization Practices actually has to recommend that vaccine for use. So they're planning to meet within 24 to 48 hours after that EUA is issued. So right now we're thinking we would have a fully recommended authorized vaccine somewhere around December, like 14th to 15th. Again, please know these are all really loose moving dates. I do think that they're fairly good to lean on, but there could be some alterations there. Moderna is moving fairly quickly behind the Pfizer. At one point, we thought there might be a number of weeks between them. Now it could be truly a number of days. If all of the emergency use authorization goes well, they're anticipating first shipments of the Pfizer could be as early as December 18th. What that looks like in the state, I don't know that exact timeline. There are about 5 different hubs, if you will, in Michigan that have been identified who can receive that initial shipment of Pfizer. Those are all hubs that have significant deep freeze, that ultra cold, -70 degrees Celsius storage. There are some in the Spectrum Health not the Spectrum Health Lakeland, sorry, the Spectrum Health Network. And then from there, it would be portioned off to local jurisdictions. So to hospitals, to local health departments. The Pfizer vaccine does come, you have to be able to take basically 1,000 at one time and use that within a 30-day time period. So there are some limitations just for some smaller areas. The Moderna will be a much friendlier vaccine for smaller rural communities just because of it can come in 100 increments opposed to that 1,000. And then the cold storage is a little bit better. So that's all kind of the pieces that are moving and working there. So we're really working on what does that mean for us right now. We're working on identifying what the numbers of those tier 1A, 1B, and 1C are. Have worked with the Area Agency on Aging to really identify what is our population in skilled nursing facilities and assisted living facilities, have worked with county emergency management to get a handle on our EMS numbers, our police, our fire, our dispatch. So trying to quantify in each of those groups who they are. We know some of those, again, will move around, but once we have those numbers, we can more easily move them where the recommended phases are and be able to plan accordingly. So now that we have some of those numbers being pulled together, we're in more of that, okay, what are the plans look like and how do we operationalize those? So a lot of this, again, will happen in drive-through. There's a lot of pieces that we're still waiting for some of this information, but recommendations where a whole crew of people at a similar or same organization wouldn't be vaccinated at once. They want to have some staggered vaccination. And again, that's just to monitor for any reactions and make sure that a whole team doesn't miss that day or two. So really working on how do we stagger our locations throughout the county to best meet the need. We've had decent weather till now, but the later we get into December, we know that snow is going to come, or at least our colder weather. So we're hoping to work with a few of our fire chiefs and utilize their drive-through space. We were actually able to do that in Chickaming with the flu vaccine. It worked really well. Again, it's still going to be a little chilly, but we have that shelter for our staff and as well as the person getting the vaccine. So we're just trying to think strategically of how many a week our department can host, where can we host them, how are we identifying who are the appropriate people in each of these tiers, and how do we coordinate with those employers. So a lot of that work is ongoing. And we're just kind of on weekly meeting cadences right now. So we have a lot of internal meetings. We are meeting weekly with Spectrum Health Lakeland because, again, one of the things that we learned and that came out of H1N1 is there was a lot of confusion of who was vaccinating who. And we certainly don't want that to be the case. We want to have really clear lines of whose role is it to reach out to what people, who is going to do that vaccination. One, that's from an efficiency standpoint. I mean, you've been hearing our numbers. Our hospital staff are tired. Our health department staff are tired. We want to be efficient with our time. We want to make sure that we're getting to everyone we need to and not duplicating. And then we know there's going to be limited vaccine. This is some of the messaging that I know Jillian and team is working on, but we won't be able to get to everyone at once. And so we really want to make sure that no vaccine is wasted. And that we can use it all in the time frame in which we receive it and can get that back out. There are definitely some aspects with this. Both of the vaccines that we're anticipating right now are a 2-dose. So the Pfizer, I believe, is a 21-day. So dose 1, and then 21 days later, you're able to get that booster. And then the Moderna is a 28 days. So, I mean, this is going to be our future for the next handful of months. Early projections have shown that between December and kind of end of April, so that kind of 4.5, 5 month time span, there is the anticipation that as a country, we would be able to vaccinate the majority of people who fall into the 1A, the 1B, and the 1C. So when we start thinking of general population, just that mass vaccine availability, that's looking to be more of late April, May. Again, all of these timelines could speed up or slow down, but that is kind of where we're at right now. So we know that the next 4 months will be a duration of getting to our critical infrastructure, to our vulnerable residents. We really want to focus on vaccine confidence and making sure that we're building that in our community, and also balancing all of the other mitigation things. Like, we're still going to need to have masking and social distancing. We're not going to have everyone vaccinated by middle of January. We're just not going to be in that boat. So there will be a lot of nuanced messaging and work that we need to do there, but that's where we're at with vaccine planning. A lot of the recommendations, again, these are not local decisions. These are things that we're working with the state and with the CDC to say, who are those first tiers getting vaccine? What does that look like? And then we're really focused on what is our local role in working with partners to make that happen. Any questions on that, or any other team members who want to jump in and cover anything that was missed?
I just want to say, Dr. McBride, you have a question or comment?
Yeah, one of my I guess issues, obviously deaths occur in the 1A group, the long-term care facilities. Is there any discussion at what point less mitigation occurs once the 1A population is vaccinated, the healthcare workers and the long-term care facility hospice people? So is there any discussion at what stage of vaccination we may open up more?
Yeah, no, that's a great question. I don't personally have an answer to that. And I think I've heard more of that question than the answer to the question. It's been more of the discussion of we can't get in the mindset that vaccination peels back everything else immediately. There will be a time period. I guess the piece I will add to that is a lot of this depends on how many people choose to be vaccinated, right? Just a certain percentage, we have to have that critical mass if we want vaccination driven herd immunity. And so there are so many moving factors to be able to even find what is that threshold and what is that trigger is really difficult to say. I do think there's some of that work ongoing, but I don't have a good, clear idea of when that is yet. Yeah.
Thank you.
I just am amazed at everything you're doing as a health department staff, Courtney. We can't thank you enough. Your clear explanations, the long hours that staff are working, Candy, please pass on our thanks. It's just extraordinary what you're doing. You've stepped up to the plate. We really appreciate it. So, are there additional questions?
I have a
Yeah,
question.
I have a
hands up,
question.
Okay, so Linda and then Joe.
I think that it's going to be important to have clear definitions in some of these categories. And I'm thinking of our staff and the 2,000 to 3,000 people that they see every day. We are essential workers. We are in the Medicare, Medicaid eyes, we are home health care. And yet we have run into a lot of roadblocks in terms of getting testing and so on. So I think that's going to be very important to understand, sort of what the categories are and where some of the people who are essential workers but don't fit in neatly into categories may be.
Thank you,
Yeah,
Linda.
I would agree, Linda. That's going to be the heavy lift. There's been, and I'm happy to share these if anyone's interested. There have been some really good ethical analysis of how the tiers have been formed and the decisions made that kind of transcend high risk from a health standpoint, from an equity standpoint, from ensuring that we're getting to a diverse population, that are really interesting to read. I think I can certainly share those.
I'd love that. Yeah, I love that.
If you do that for the entire board, that would be good. Joe, you had a question or a comment?
I just was questioning, as we administer all these vaccines to ultimately most of our population in the county, the follow-up on how is that going to be tracked as far as have they really gotten immunity, what side effects, and so forth. And we'll have maybe 3, even 4 different vaccines, and the efficacy of each one, is one better than the other as the process goes along. It seems like a huge amount of data, and if we're having trouble now tracking the folks that are test positive, it seems like that could be a pretty significant initiative.
Yeah, no, that's an incredibly important piece of this. And definitely, I mean, locally, we will have to have in place, how are people contacting for care if they need it. From a national level through VAERS, there is going to be a huge push. I think it's called vSafe or vTrack. There's 2 different systems and I keep mixing up the terms. So I'll get the right one for you here in the next few weeks, but I think it's vSafe. But it's essentially a program that anyone who receives the vaccination is going to be not required, but heavily encouraged and recommended to enroll in, where basically for 6 weeks after receiving the vaccination, you will get a daily text and check-in. And then if you're experiencing anything, you can report it through that system. If it's anything more severe, it's a direct link to a VAERS customer service. So this is where we would normally report any type of vaccine error or concern. So there are some national systems like that in place, certainly locally. I mean, the other caveat is we're going to have, and we've been starting to think through how do we do this in an efficient manner, but we're going to need to notify people when their 21 days or 28 days has passed and they need to come back. To your point of there could be 4 vaccinations, it could get really complicated because you need to have your second dose with the same vaccine that you started with. So it's really not in the interest of our community to say, we want all of them, we want all of them. We want to really have vaccines that we can make sure that we keep getting that second dose. And that is the plan, even at the federal and state level. The distribution plans are, if we get Pfizer and the first 1,000 that we give out, we've been told you don't hold that back. Give out 1,000, you will get the second dose of 1,000 to ensure that you're able to do that. So some of that work has been pre-done, but yeah, there will definitely be a lot of nuanced coordination pieces to this. It's not as simple as go get a vaccine, show up at any other place you want and get the second, you do need the same vaccine. And then, yeah, the reporting, it is going to be an emergency use authorization. So there's still a lot of that study piece that needs to happen. So there are some national systems though that I think will really support that. And I think it's V-safe, but I can send out that information too. Yeah.
Okay, thanks.
All right. Are there any additional questions? Yes.
Just one more. I think Johnson & Johnson is a one-dose vaccine. Do you have a sense of a timeline for their approval process?
I don't. Dr. J, have you heard any more on that? I don't have that.
Dr. J, you need to unmute.
Am I good?
Yes.
Yeah, I think they're 3 to 5 weeks out. There's currently 7 more vaccines in phase 3 trials now, and they're one of them, but I think they're just sort of in the beginning end of it. So it's going to be a while before they come out. By the way, in England this morning, they voted to their EAU was passed to get the vaccine, and they're probably going to be starting real soon now. So they're about a week ahead of us, and they're going to apparently they're in line for 10 million doses of Pfizer, and apparently the United States is in line for 20 million doses, is the way Pfizer's playing out for by the end of this year. So that's all good news. But there are 6 or 7 other vaccines coming down the pipeline, within 5 to 10 weeks or so, maybe. And so that's good. You're right, it's going to be confusing, but I think we can track who got what vaccine. I don't think that's going to be that hard.
Yeah, I think there's good systems in place to track. MICR will be something that is used. It'll be a required use, so we will have that in place. Yep, agreed. I think it'll be on the communication end, and I do want to give Jillian 5 minutes to kind of just wrap us up with some of the communication pieces. I think there'll be a lot in that of just making sure people understand what they're receiving and what are the next steps and how we're following up with that, plus all the other things. Jillian, do you want to mention anything there? Sorry, I know we went a little long on vaccine.
That's fine. This is a communicator's dream, something that's super complicated, nuanced, and hard to get across to the public, and you don't have any information to share at this point. So this is where we're at. So yeah, there's definitely going to be a heavy lift for public health communicators to make sure that we are getting very clear, very distinct information, building confidence, and making sure that people understand when they can get the vaccine, what they need to do next, when they need to get their second dose. So we're planning for that. But again, with the limited information, the timelines that are shifting still, the logistics that are yet unknown, it is difficult to give many specifics. So at this time, we are, as you heard with what Courtney reported, just trying to give as much as we know right now, but there's certainly going to be much more to come. What I'm very hopeful for is that, similar to some of the COVID funding and flu funding that we were able to receive this year, we will receive some funding for vaccination promotion and education, and make sure that we can actually get these messages about COVID vaccines in front of people a little bit easier, using some of our paid methods rather than just the free methods that we have available to us. So all of that is ongoing. The PIO group of communicators in the state of Michigan have had conversations. We've connected with a lot of communicators across the country. So there's definitely a lot of attention turning towards how will we build a successful campaign to make sure there's clear information that will help build confidence and ensure that people decide to get the vaccine.
Thanks, Jillian. Any other questions about where we are with COVID-19 or case investigation, vaccines, all the things?
Thank you very much for a very lucid presentation. Just appreciate it all. So.
All right. Well, I guess with that, moving on, we had under program spotlight to talk about the Community Health Recovery and Improvement Plan. I really think with our time that could wait till January. Definitely want to share that with you all. It's more just to say we're still thinking long-term and doing a lot of those health improvement things we know wrap around our COVID response. So if it's the will of the board, I'm okay holding that till January. I think we have some other things that I don't want to shortchange.
I agree with you. I would like to move on and just have Bill bring us up to date on what's happening with the Board of Commissioners and also the reporting structure for the for the Health Department.
Great. Thanks, Peg. Well, and some of this is going to be for Administrator Doucette as he comes on board. He's been with us 6 months and is doing a great job. He wants to be more involved and more aware of things that are going on within the Health Department through the Board of Health. And one of the things that he is working on to standardize across the county is that all departments that fall within his organization, and the Health Department is one of those, the leader, and in this case, that's Nikki as the health officer, will have a direct reporting relationship to Brian in the future. Now, this doesn't in any way reduce the authority, effectiveness, et cetera, of the Board of Health. And I've talked to Brian about this. Peg and Nikki and I met with Brian several weeks ago to talk about this reporting addition, I would call it. And I think everybody's very comfortable with it. I think historically, and this predates my time, the Board of Health and the Health Department have been more remote from the administrator than most other departments in the county. And I don't know why that was. I think it may have been something with that administrator. Brian wants to bring these ties and collaboration into a closer focus. And I applaud him for wanting to do that. Peg understands and is very supportive, and Nikki is as well. So sometime in the next several months, I think this board will see a fairly minor change to Nikki's job description, which will memorialize a reporting relationship between the health officer and the county administrator. And I will leave that for your thinking, and Peg, I'm sure that Brian will be bringing that forward sometime in the next several months. But since I was instrumental in getting these discussions going, I felt I better lay it out there first. The other thing I wanted to mention, there's a continual discussion at the Board of Commissioner level about an emergency declaration like we did in the spring. I think we've been around. I think that part of the issue is just how far you have to go with an emergency declaration. We're certainly in an emergency situation, but the debate that I think continues to go on surrounding this issue is whether or not that requires us to invoke the offices of the emergency office, the EOC, which was involved in before. And there's a difference of opinion as to whether we should do that or not. And I will also leave that to Administrator Doucette to move on in the next several weeks with the Board of Commissioners approval. And then finally, I'll try to do this quickly. I had a 15-minute speech ready, but I'm not going to bore you with that. I very much appreciate your resolution, as I said. It has been a true honor for me to work with you all for the last 6 years. And I think that a couple of things. Number one, at the outset, liaison to the board almost sounds like a spy. And I have never taken that as a role. When I came on board with your assistance and your cooperation and your welcoming attitude, and I'm talking staff and board, I felt like I'm an advocate for the health department. And as one member of 12 who governed the county, I think that that's exactly what this role needs to be. The work that is done by this organization is so complex, so highly professional, and to a great extent, so unperceived by our residents that the Board of Health and the liaison, I believe, need to be this advocate to keep that critical work in the forefront of our residents, because it's taken for granted. Certainly the work that's being done right now is not, and I know every one of you want to get back to what you were doing before. But the Board of Commissioners and our residents need to be continually reminded of how critical the work is that this organization provides. So, Mr. Doucette, that's my opinion on that. The other thing is, I will say that there are a lot of boards that I've worked on. There are a lot of boards in Berrien County. In my opinion, there is no better, more professional, more engaged board in Berrien County than the Board of Health. Each one of you is extremely experienced, extremely knowledgeable, which is essential given the complexity of the work, and extremely involved. And it's been a pleasure for me working with you all because you are so involved. So another point, Brian, would be that this is a great organization for Berrien County, for the health department. And I think it's an organization that could be looked at and emulated by some other boards that could be a lot more effective for the residents of Berrien County. So, I think I fell into a great job with y'all, and it has been a pleasure each and every week, in spite of the difficulty of the subjects that have to be dealt with. So once again, thank you all so very, very much for your collegiality and your support. And that concludes my comments. Thank you.
Thank you so much, Bill. I appreciate it. Thank you. Brian, would you like to say anything?
Sure. So just to address a couple of Bill's points, the easy one is the emergency declaration. The declaration is something that is continuing to be discussed by leadership at the Board of Commissioners. I anticipate that some form of the declaration is going to be necessary, and it's tied to what you all are doing right now, the use of Zoom meetings, the use of virtual meetings. The Open Meetings Act has been amended into 2021 to allow the continued use of virtual meetings, and that's for all public bodies. That would be counties, cities, villages, townships, even school districts and colleges. But the caveat there is that a local state of emergency needs to be in place to make that Open Meetings Act allowance effective. So this is something that we continue to talk about at the county administration building, and it really just comes down to the timing. It is something that, if it is to be permitted in 2021, we'll have to deal with this month. As it relates to the overall state of emergency, I think that just about every single week since summer, Nikki has provided a really thorough brief to some of the board members, and they just continue trying to determine what is the very best path forward. So that then leads to the segue about the reporting relationship. Commissioner Chickering said it best. He talked about being an advocate for the organization and trying to be there to assist with the gathering of resources. My goal, my plan is to continue in that same vein. I've worked with Nikki for many months. I've been really impressed by her. I've been extremely impressed by her team. And I hope that there's a day where we don't have to work so closely together, because that will hopefully be an indicator that things are calming. But that's not our reality right now. And so as it relates to that reporting relationship, while there will be a modification to the job description, I view it as the burden is really on me to continue to provide resources to help Nikki and her team get the tools that are needed to ensure the effective rollout of the vaccination clinics and any other needs that they have. With that said, I've been really impressed by the team that's working over there, and I look forward to continuing to work with them over the coming months and hopefully years to come. Does that address the? I tried to move quickly, and I hope I summarized what's being planned.
I think you've demonstrated by the collaboration that you are a true advocate, Brian, and we really appreciate that and look forward to that. I hope there might be an opportunity for the Board of Health to meet with the Board of Commissioners at some point in a joint meeting, just to build stronger connections there. So
I think that's a great idea. And just 2 weeks ago, the health department teamed with Lakeland to provide an update to the Board of Commissioners. That was something that I got a lot of feedback from the public as well as from the Board of Commissioners on how much value they got from that. And I will absolutely bring up a joint session with the board chair and work to make that happen.
very good. Thank you for joining us. We really appreciate that you took the time today. So
No problem.
I know you've got a lot on your schedule. Is there any other more Board of Health discussion, or shall we move to public comment? All right, Jillian, I hear nothing from the board. Is there public comment or questions that have been raised?
There are no public comments.
All right. So no board prep meeting. Our next meeting is January 6th. I hope you all have a safe holiday session and time together without your families. So just be safe. So thank you so much for your service to everyone, to Bill,
Thank you.
everyone. Thank you.